Hear me okay? Oh, fantastic. I'm going to start sharing a slide and will introduce myself as that comes. Okay. So can you see my slide okay as well?
Do you want to go into presentation mode? It's up to
Yeah,
you.
yeah,
Okay,
yeah,
there you go.
yeah, of course, of course. So good morning, everyone, and thank you for joining us at 9 in the morning. Much appreciated. My name is Cyril Eshareturi. I'm the BAME Commission Public Health Program Lead at the local council, so the Department of Public Health. I'm going to be speaking to you today to share, on the one hand, the tool that we designed as a consequence of what we had been told by our residents. But I think, on the other hand, and more importantly, I wanted to share as a tool to kind of inform your practice moving forward. The first thing I would like to say before I even start this presentation is to preface the presentation by actually saying um, trauma-informed approaches to healthcare and being culturally appropriate in how we deliver health interventions are actually not mutually exclusive. To my mind, they're actually symbiotic. And what I'm going to be sharing would be how both approaches, to an extent, support each other and to an extent can both collaboratively inform our interventions moving forward. So that will be the step. Towards doing this, I'm going to give you some context. I'm going to explain where this toolkit has come from. So why did we do what we did and how did we do what we did? So that will be the context. I will then share the project that we actually conducted that led to the toolkit. I will then share the toolkit with you, but in doing that, I would reflect on how the toolkit is actually, to my mind, again, very supportive of trauma-informed approaches. So again, I'm going to share the similarities with you. I will speak to how we have used it in practice and how we intend to continue to use it. I will then share again the value proposition. Some of you are senior clinicians, some of you are senior leaders within the organizations. But nonetheless, if that's not even the case, to my mind, I kind of would think that if you want to carry out any particular intervention, if you want to work with marginalized communities or inform health intervention in the trauma space, one of the key things that we have to reflect on would be the business case, the value proposition. Why are we doing what we are doing? And what is to be gained by doing what we do? And what I'm hoping to share would be reflecting on why it is important that we consistently adopt these trauma-informed approaches to our healthcare, to our health interventions, I beg your pardon, but also underpin that by being cultural appropriate. So I'll do that by proposing some value to doing that in practice. And of course, there will be space for us to kind of discuss what we have heard and just share thoughts, but also it would be a space for me to convey the support that potentially the public health team can offer you in terms of ensuring that your interventions are also culturally appropriate. So for context, I want to start with a brief that we had for health communication and engagement. So we had the BIM commission in Tower Hamlets, and this was between, it was around, it was around the period when COVID was a big thing. So the pandemic, 2021, 2022, thereabouts. And the intent of the commission really was to address the inequalities experienced by Tower Hamlets BAME community by delivering tangible and practical actions which will deliver real change in the lives of Black, Asian, and minority ethnic communities. So to our mind, there were two things this commission wanted to achieve. The first was to explore inequalities in that space, but more importantly, to come up with practical actions to address those inequalities. One of the things that we consistently were told was that the manner and way we were communicating was not culturally appropriate. It was clear whether it was in GP practices, whether it was in sexual health services, whether it was in response to COVID, it was a consistent recurring theme. Consequently, our director of public health then felt that it was something we had to explore. And in operationalizing the brief, what we were told to explore was to review our health communication and engagement strategy with residents towards ensuring that guidance and important messages are, on the one hand, culturally appropriate, available in different languages, but also uses different approaches to ensure messages reach different audiences. But more importantly, this was also aligned with our health and well-being strategy in Tower Hamlets, which is that we should ensure that resources to support health and well-being should go to those who most need it. So this idea of equity, feeling connected and included is a foundation of well-being, and the importance of this should be built into services and programs. Being treated equally, respectfully, and without discrimination should be the norm when using services. You can see how that relates to trauma-informed care. Health and well-being information and advice should be clear, simple, and produced with those who will benefit from them. So again, recognizing that the lived reality of our residents is one where literacy might be an issue, the agency to advocate on their own behalf might also be an issue. People should feel that they have equal power in shaping and designing services and programs that impact on their health and well-being. So understanding people's lived realities, situating power with them. We should all be working together to make the best use of the assets we already have that support people's health and well-being. To my mind, this last point speaks to this idea of also recognizing that individuals and the reality in the context of the spaces and experiences that they have are actually our assets. And if you reflect on the idea or the ethos of trauma-informed care, it is the recognition that the trauma that individuals have encountered informs how they interact with services. So we need to understand that concept by situating power with them and recognizing that that reality places them in a position of power. And for us, it informs this idea that they are also assets to inform interventions moving forward. So what we did was we took the brief we had been given and we operationalized this brief through a project. So the aim of the project was to develop and implement guidance for culturally appropriate communications and engagement. Accordingly, the objectives were to evidence the importance of cultural appropriate communication and engagement, to co-design guidance on culturally appropriate communication and engagement with our residents, but also to embed guidance on cultural appropriate communication and engagement into the working practice of all council departments through bespoke training. So if you cast your mind back to what I said in opening this presentation, I said on the one hand, I want to share, but on the other hand, I want to speak to how we can begin to think of how we can embed the toolkit moving forward. So this was a project that was sponsored by our Director of Public Health, Dr. Suman Banerjee, and I kind of led in terms of operationalizing the project. We adopted a two-phase, so in terms of the pragmatics of the project, we adopted a two-phase project. So what we did was we triangulated documentary evidence with qualitative data. So the first phase was a review of the literature. We wanted to understand from the position of the literature, what does cultural appropriate health communication and engagement look like? And the literature told us a variety of things. It told us things like the importance of co-design is associated with being culturally appropriate. The idea of using culturally trusted settings. So this idea where you recognize that individuals might go to a particular butcher to buy halal meat. That space where they go to kind of get that halal meat in the context of maybe religion or culture might be something that we might want to reflect on in the space for health. So if you think about Black and African Caribbean women where they go to hair salons to make their hair, or to cut, or men where they go to salons to cut their hair, we could use that space as a space to kind of promote health. So that those settings are referred to as culturally trusted settings. Again, it could be places where they go to fulfill religious obligations and needs as well. They speak to the importance of ensuring that we avoid technical languages when we're communicating health messages, avoiding that languages of stigma, of inequalities are avoided as well when we communicate. So these were things that emerged from the literature. So what we did was we then recruited a sample from our local voluntary sector organizations that work across the council. What we said to them was, we are trying to understand from the lived reality of our residents what cultural appropriate communication should look like. We know from the literature what the literature posits is cultural appropriate communication. Nonetheless, and more importantly, what we want to know is whether what the literature is saying corroborates what our residents feel. On the other hand, if what the literature is saying is not what they actually think cultural appropriate communication should look like, we want our residents to tell us and inform what that should look like. So subsequently, we kind of shared this with all the CVS organizations that we have. They got in touch with the residents, and the residents then came back to us of their own volition, expressing interest to contribute to this piece of work. Subsequently, we then had interpretivist, open-ended qualitative interviews with them. So it was really, really open-ended. So I say semi-structured interviews loosely here because the interviews were not really semi-structured. They were very much open-ended because all we did was we said to them, this is what we found in the literature. We gave them time. We sent it off to them. We gave them time to reflect on it. If individuals needed translation, we translated for them. If they wanted clarification, then I called them up and I clarified some of those issues that came up from the literature. They spent a few days, so in some instances, some individuals spent about a week trying to process the information, trying to understand what came from the literature, but more importantly, how their reality could inform what we're going to do. Then subsequently, we then had open-ended interview, and the whole structure of the interview was, thank you for joining this interview. Do you have any questions with regards to the materials that I had shared with you before? And it would be yes, it would be no. Once the questions were addressed, it would then be, please tell me what are your thoughts with regards to the materials I shared with you. And that was it. We just explored their thoughts. Off the back of these interviews, the findings led to a toolkit which basically spoke to what they wanted to see in the context of cultural appropriate communication and engagement. So I'm going to share that toolkit with you next. So what we had was an 11-item toolkit that basically conveyed those issues which they felt were important and had to be addressed. And the way we have structured this is, and I'm going to go through the toolkit with you, is that for every item, we're hoping that this is a toolkit for practitioners to use. And the thinking behind this is that for every item, if you address that item, then you put a yes or a no. If it is not applicable to the intervention that you're providing, you just tick not applicable. But more importantly, in the comment section, we're expecting professionals to evidence their decision pathways. It could just be a line. So for instance, the first item there says, has the message been co-designed with communities? If you have co-designed, then you take a yes. And in the section, you tell us what you have done. It could just be 2 sentences to say, to just basically convey what you did in the context of co-design. Now, what this forces us to reflect on and do is that it forces us to reflect on whether what we have done is truly co-designed, is truly situated power with the individuals that we are serving. For instance, individuals might say, well, I had a focus group of 5 people to inform this intervention or this message. Well, actually, is that true co-design? Again, it just forces you to reflect on your practice in being culturally appropriate. In terms of the explainers that we have below, so these explainers are explainers that came out of, the reflections that we had in the interviews. So what they mean in the context of co-design is this idea that we should work with our communities to design the message from conception to delivery. On the one hand, it is important that we work with the community to conceive what the message should look like, but more importantly, we should also work with them in delivering that message. The second item is, has technical language been avoided? So specialized health terms should be avoided, and the message should be validated by the communities you are aiming to engage with. The third, has the language of requirements and mandates been avoided? Focus on the benefits of engaging with the message alongside government mandates or requirements. We recognize that there are contexts where there is a government mandate. There is a mandate for us to actually disseminate a message in a particular way. What we are saying is focus on the benefits alongside that mandate. If it's a requirement, then a requirement is a requirement. But it's important that we focus on the benefits while, highlighting what that requirement is. Does the message induce fear and or stigma? Ensure the message is validated by communities, particularly if there are issues around inducing fear and or stigma, because fear is very different from stigma. But if there's one or the other, it is also important that we do that. Will compliance with the health message disadvantage communities? It is important to be aware of challenges which may face communities in complying with the health message. So these are the first 5 items in the toolkit, but I want you to reflect on how this actually corroborates a lot of what we do in the context of trauma-informed care. Trauma-informed care has 6 key principles. I'm not going to speak to what these principles are. I think most of the individuals in the room would know what they are. The idea of safety, trustworthiness and transparency, peer support, collaboration, empowerment, and then cultural, historical, and gender issues, ensuring we address that. If we think about this idea of the checklist, the first point there, has the message been co-designed with communities, collaboration, trustworthiness? You can see how this aligns. Technical language being avoided. Again, you can begin to see how this aligns. Once you're ensuring that you're collaborating, once you're ensuring that there is that peer support, they will call you out if you're using technical languages, if you're using languages which are stigmatizing. Has language of requirements and mandates been avoided? If the language is so that actually that's what it is doing, they would actually tell you, they would call you out if you're truly co-designing, if you're truly understanding, if you're ensuring that individuals with trauma, individuals with lived experience are informing the interventions that you're providing, then they would actually call you out and tell you that you're actually falling short on some of these things. We think about this idea of whether the message you're intending to deliver induces fear or stigma. If you think about homelessness, right? If you think about that context, you understand that when you're reflecting and having conversations with individuals, then they would call you out if you're doing things where they feel you're perpetuating their trauma. It's like when we have when we have when we try to collect data from marginalized communities, and sometimes you speak to that data collection process as interviews. You say, oh, I'm going to have this interview with you. Yes, we understand as professionals, some of you would have masters and PhDs and whatnot. You'd have degrees, but in terms of research, it's called interviews, whether it's qualitative interviews, semi-structured interviews, that's what it's called. But actually reflect on the reality of an individual who basically is maybe a refugee, maybe an asylum seeker, maybe even an individual who has had some sexual trauma in the past, when they had to engage with the criminal justice system. A lot of the interactions with the police were interviews, right? So again, that's the way we use language to construct meaning could perpetuate trauma. So why not conversations? So again, this is the general idea. If you're co-designing, if you're truly situating power with these communities, they will tell you, they would call you out. So you can begin to see that being culturally appropriate and using this toolkit to be culturally appropriate in our practice is actually not mutually exclusive from being trauma informed in what we do. Will compliance with the health message disadvantage communities? Again, the same general idea, the same ethos, this idea of safety, idea of ensuring that there's empowerment and that we're giving the individuals that we serve a voice and a choice. The sixth item on the checklist speaks to this idea of credible sources to disseminate information. Who are the individuals that individuals individuals in spaces of trauma trust? Who are those individuals, and how do we know that they are the individuals that they trust? So this is the idea of credible sources. Work with communities to identify trusted, credible sources and use these sources to disseminate the message. It is important to reflect on this point that we should work with communities to identify trusted sources. I can sit down here and I can tell you that it is my opinion that if I was providing an intervention for an individual who has had some sort of experience around domestic violence, that I might think um, that a particular charity might be a good, might be a good, might be a good source of trusted sources I could sit down and that might be what I think is appropriate. But actually, that construction of reality is flawed because that is not my reality. I'm in a very powerful
Yeah, I'm just
position by
listening to
providing.
some work thing, but it's okay.
Okay, I'll just carry on. So again, that reality is wrong because I'm in a powerful position and it is not my reality. So what this is advocating for is that we work with individuals whose reality is one where they've had experience of domestic violence or are victims of domestic violence, and they can then inform who those sources are that are credible, trusted sources. The general idea around item 7 is, are we disseminating in multiple languages? So again, this idea that we should disseminate using a plethora of languages. So if you're working in spaces with ethnic minority groups, say for instance, Tower Hamlets, we know we have a big Bengali population, a big Somali population. So interpreting and translating in those languages. Are we disseminating using multiple media? Ensure that we disseminate using a plethora of media sources, social media, radio, TV, etc., leaflets, and the rest. Have we explored the use of cultural trusted settings? So this idea that your butchers, the idea that the temples, the mosque, the churches could actually be settings for health. Have we made provisions for questions and clarifications following message delivery? Ensure that once the message has landed, that individuals have the space and time to process and then come back to us with questions and clarifications if they want that. Is the message accessible to people with disabilities or special needs? Also recognizing that we live in a society where, unfortunately, it is very, very easy to unwittingly miss individuals with special needs or disabilities, but it is important that we consider their needs in designing this message. But what was really interesting was we set out to explore cultural appropriate communication and what that looks like in the context of the reality of our residents. The first 10 items, you can see that they were actually a mirror image of some of the things that were coming out from the literature, but item 11 was very insightful in that residents were maintaining and confirming that actually a lot of the time, our reality in terms of our special needs or disability are more like an afterthought. When these messages are being designed, they are not at the fore of the designers of the message. And consequently, this speaks to this idea of ensuring that when we co-design, we have a sample that is truly representative of the communities that we serve. Again, we can clearly see how this aligns with trauma-informed care. You can begin to see credible sources, this idea of collaboration. We can begin to see disseminating in multiple languages again, people, giving people voice. We can begin to see multiple media in there. Cultural trusted settings, we can see that it's there in the principles, provision for questions and clarifications, again, voice and choice, people with disabilities or special needs, collaboration, peer support, again, even safety. Um, so clearly you can see that what we are proposing in the context of being cultural appropriate is actually symbiotic or to an extent, even a mirror image of what it is to be trauma informed in delivering health interventions as well. The manner and way we have used this toolkit in Tower Hamlets, and we continue to use this currently, we've used this to underpin the engagement of the community outdoor gym activation program. So this is a program which is designed to look at the outdoor spaces we have across Tower Hamlets and to an extent begin to turn some of those outdoor gyms into gyms which are currently active, because what we have is we have outdoor gyms which to an extent in some places are dilapidated, not being used. And so we're using this toolkit to inform the consultation exercise with our communities to inform what the gyms should look like, how they should run, etc. We've also used the toolkit to underpin and inform co-design sessions to inform the assist letter sent out to parents ahead of reception in January 2023. We've used the toolkit as a reference guide for a campaign around the theme of living well for less in the context of the cost of living crisis. And it also helps the scoping of different routes of engagement with the community towards the design of the proposed Tower Hamlets Play Street program. Currently, we're exploring using the toolkit to underpin messages around pediatric asthma. We're currently looking at how we can use the toolkit to inform access to primary care for children and young people. This is this idea that a lot of children and young people do not realize that they actually can access their GPs. I think it's from the age of, 13 or thereabouts. Please do not quote me on the age now, but the idea is children and young people can actually access their GP without parental consent, but they're not aware of this. And it's trying to highlight that right that they have as well. Again, using the toolkit to underpin some of these things. So we have a couple of projects in the pipeline, which the toolkit is being used to underpin moving forward. In terms of the value proposition, I'm going to try and barrel through this bit now. From what I have shared with you and to my mind, I want to reflect on three things. The first is this idea of co-production. Co-production theoretically, and there are several authors that have written about this, but you can kind of break down three key themes in the context of co-production or even co-design. The first is this idea that whatever we do, there should be evidence of being, evidence of equality. There should be evidence of reciprocity, and there should be evidence of agency. So of course, equality, ensuring that, the principles around equality are adhered to. In terms of agency, ensuring that individuals, that we situate power with individuals such that they have that right to, such that they have that ability to advocate on their own behalf. It's one thing to situate power with an individual. It's another thing to situate power with them such that they then develop that ability to advocate on their own behalf, irrespective of literacy, irrespective of ethnicity, irrespective of gender. So that's this general idea of agency, and reciprocity is very important. For me, it speaks to recognizing our powerful position, recognizing that every time we go to the communities that we serve, we need to recognize that whilst we might go there and say, oh, I would like you to co-design with us, oh, I would like you to inform this intervention, we also have an agenda. We have something that we are going to be achieving by them co-designing with us, and we have to be honest with them. This idea of honesty in the context of culture is called cultural honesty. So for instance, I go to an individual um, who is a victim of domestic violence, and that's because I'm providing an intervention around domestic violence. And I say to that individual, I'm trying to design this service, but I want you to co-design the service with me so that it informs what the service looks like, who it serves, informs everything around the commissioning of this service. So that is what I say to them, and I say, I'm situating power with you. Whatever you tell me, I will do. Well, actually, what you have done is very important and it's very good, but it's only half of the job, because what you have done is you've situated power with them, but have you truly told them what you stand to gain by them telling you, by them engaging with this process where you have situated power with them? So what we expect is this idea of reciprocity by you co-designing, by you telling me all this is what I stand to gain. I'm going to inform this service, I'm going to create this service, I'm going to commission this service. And as a consequence of doing this is what my organization stands to gain. So this is the idea of reciprocity. So if you think about how this is aligned with the idea of being trauma-informed and being culturally appropriate, we are advocating that we should co-design with our communities. It speaks to equality and reciprocity. We are talking about ensuring that you evidence power sharing, agency and reciprocity, that we address stigma, agency and equality, but more importantly, that we demonstrate in all these that we are culturally appropriate, agency, equality, and reciprocity, the idea of co-producing and co-designing. In advance of the next section, I want to leave at the front of your minds two quotes which I think speaks to the importance of being trauma-informed, but also being culturally appropriate. The first is from a YouTube video that I found on trauma-informed approaches. And it maintains that being trauma-informed is a journey and not a label. It is an approach that helps to support people through compassion and power sharing with understanding. I like that last line because I think it speaks to everything in terms of cultural appropriate communication, in terms of being trauma informed. It is this idea of empathy without being patronizing, the idea of compassion, the idea that we share power, but in doing that we also underpin that with understanding. And I think it speaks to why we should also be culturally appropriate as well. The next quote is on cultural appropriate communication. And it's this idea that in being culturally appropriate, it ensures that we get our communities on board, but more importantly, that the interventions that we deliver consequently will be cast in stone. It is this idea that if you want to go fast, well, we can go alone. We don't have to be culturally appropriate. We don't have to be trauma informed. But if you want to go far, we have to be culturally appropriate. We have to be trauma informed. And to do that, we have to go together with the individuals that we serve. Thank you for listening. So I'm going to just move on to questions and clarifications if you have any. Any questions, any clarifications, and then that will open up the discussions. I'll just stop sharing my slide.
I have a question. Thank you so much for that. I had a question while you were talking about the interview process, and I should know this because I have heard you talk about the project before, but I thought it was really interesting that you gave people so much time to like process the information, and that the interviews were relatively unstructured. Was that on purpose or just something that, because it seems like it is part of the process, but was it something more so that you planned in or rather realized that was needed at the time?
It was what I think it was both. So it was
Okay.
planned in to give time, but subsequently we realized that, well, actually individuals needed more time. So for instance, you send it out and it was more of a week time. And someone came back to you after a week and said, well, actually, I do not understand this point. Can I schedule a phone call with you? Can you give me a ring? I would just say, yeah, that's fantastic. Just let me know when it's appropriate for you. So sometimes it took 2 weeks, sometimes it took 2.5 to 3 weeks, but it was something that we planned in. But over time, the pragmatics of it just meant that it just extended. But I think that that process in itself kind of just meant we're situating power with them. It was saying you are informing this process. It's not one that we are informing. Whatever works for you works for us.
Great, thank you. Does anyone else have questions? Kath, I know you have to leave soon. Any reflections? Not to call you
Sarah,
out.
can I just say, I mean, what a really, really important piece of work. And I'm really excited to look at that framework in a little bit more detail. So and it's great to hear about the examples of how it's been used, particularly with regard to children's services, as that's my area of focus as well. So really, really great. I was just reflecting actually on a piece of work that was undertaken throughout last year with regard to children's end-of-life care and palliative care and needs assessments, and how we utilise that work to actually move our services forward in the future. And I did pop an example in the chat box and a link to that work, because I think there are so many themes that actually come through with regard to trauma experiences that our families have actually had in the past, and how that does inform, as you rightly reflected, the use of services as well, and some of the cultural variations that we've actually got. And there's a particular slide in the pack there, slide number 42, that really draws out the experience of our white Caucasian families in terms of accessing children's end-of-life and palliative care services versus our Bangladeshi families and their experiences of accessing services. And for me, it was a real wake-up call to actually see the stark variation of end-of-life care experiences. White Caucasian family, very peaceful, understanding the context, the information, accessing services at home. Our Bangladeshi family accessing A&E, prolonged resuscitation, stay in intensive care. A very traumatic set of memories will have been created for that families, which is why it's so important that the work that you're doing allows us to have conversations and to think about how do we co-produce services going forward, because those families will carry those memories for the rest of their lives as well. So I just wanted to share that experience and to reinforce how brilliant your work is and how important it is. And I'm really looking forward to actually sharing your framework. We've got a small conversation that's happening at Barts Health, and I'd really love to invite you to actually to join us to discuss this further if that's possible, Cyril. But thank you, Angela, for the opportunity to reflect. Really helpful.
Fantastic. Thank you so much, Kath. So two things there. In terms of your reflection, in terms of the experiences, it's not only even in end of life care, it's something that we see across the board. So yeah. Secondly, I really would like to work with you in supporting that piece of work as well. What we're really trying to do with this toolkit is we're saying, well, it's come from Tower Hamlets, but it's something that we want to share across the system. That's something that we intend to do. It's something that we're even currently doing. So I would be touching base with you offline just to see how we can progress action on that. So thank you so much for the offer. And I love to talk about this toolkit now. So it is my mission to embed use across the system. So I will be in touch, and I'm happy to come in to speak to colleagues in your team about the toolkit as well.
Thanks. And then we've got a hand up from Tesley.
Thanks, Angela. Yeah, thanks very much, Cyril. As I mentioned earlier, I commission services for people with problematic drug and alcohol use in Tower Hamlets. And as you can imagine, there is a lot of stigma, particularly for certain communities. So, how do we make our services, you mentioned services being culturally appropriate. There is co-design in our system. I was multitasking actually when you were delivering the presentation, so I might have missed this, but I just wondered whether you use platforms like Care Opinion. So in our services, there's a platform that service users can feed into, and there's a link there to Care Opinion. But do you use platforms like that to gather feedback? Okay.
I would explore that, but yeah, no.
Because I think that could be potentially a rich source of information, but I don't know where the feedback that that consumers of health and social care services, I don't know where that information goes. I've never had sight of it. I don't know if anybody else knows.
I know one example. Thanks for sharing that, because I feel like maybe that's interesting for other people too. But I'm aware that I think Health Watch do kind of like a mass sweep of different public sources of opinion. So for instance, they'll look at Google reviews of different doctor surgeries or GP surgeries and kind of bring it all into one database, just as one example, although it's not always specific to cultural competency or trauma-informed approaches per se. It's more so what people are saying in general. Should we go? Oh, I can see a hand from the colleagues in the room, or in that room over there. Do you want to come in?
Okay, yes. Can you hear me? Or do I need to move?
Yes.
Can you hear me?
Yeah, we can hear you. I can hear you.
Okay. Yeah, so thank you very much for that presentation. I think it was really interesting for me to hear, and I'm extremely excited at part of this conversation today. And you've said a lot of things about co-designing with communities, and I'm not even sure if this is a question or just like maybe food for thought, because when we talk about communities, like within a particular community, there's still a lot of differences and variations. So for example, I would say if you were to bring me into a service, say, would like you to co-design this, like, can you look at this? Is this language technical? Is this or is this that? At my own level, there are some things that you would say to me that I wouldn't consider technical. First of all, because I also have like a background in like pharmacy, so I'm very familiar, and it's just become like part of my everyday language. Well, if you were to bring my mom, for example, same community, we were both Black women, we're both Nigerian, we've both been raised in the same hometown, the way you would need to communicate with her would be different from me. So I was just wondering, is there really anything in that co-designing that allows for that kind of like variation? And also, for example, I'm Christian is what I'm Christian, then I could have a friend that is Muslim. The way that some of the things that you might say to a Muslim might not be like let's say to me, might not be well received by the other person. So I'm just wondering, like, is there really anything that that ensures that people from like, just different levels of education, religion, and all of those things within the same community are given, their voices and are treated the way they would want to be treated? I think that's one. And then the other I was just thinking about, quality assurance for some of this messaging in different languages. And I'm saying this because I sat in a meeting with a few lived experience practitioners, I think last week. And, one of the things that came up was, they were really, so this person was a carer for someone that was accessing mental health services. And they got a letter in their own language. And, they were actually excited that, oh, this is the first time they've ever gotten a letter that was sent in the language.
I think that, sorry to interrupt you. I think your audio just dropped as you were talking about having received the letter and being excited.
Okay. Yeah, so is that better?
Yes.
So, this person was excited that they've received this letter in their language, but then they couldn't understand it. So apparently, like, it wasn't like good quality translation. And it's like they could pick some of the key things, but they didn't really know what the letter was as a whole. And I think these people spoke pure Bangla, I think, and they couldn't really understand what was written there. So I think there's also something, maybe a caveat there to say something about quality assurance for documents that'll be going out with key messages to different people in different languages. Yeah, so those are two things I wanted to say. Thank you.
Thank you so much for sharing. So in terms of the first point you raised in terms of co-design, the thing around co-design is, if you think about it, if you're doing it correctly, then that shouldn't really be an issue, because I reflected on this idea of co-production linking to co-design. Is this idea of agency as well. So who's in the room and what level of agency do they have? So for instance, if I was co-designing a particular intervention, my sample should reflect the communities that I serve. So I know I have individuals who are literate. I also know I have individuals who are not, I don't want to use the word illiterate because I do not think anybody is illiterate, but I have individuals who are not literate in the Western sense of, in terms of education, etc. I might have individuals who do not speak English as a first language. It might not necessarily be their mother tongue as well. So again, there are several variations as to who's in that group. The onus therefore is on you to recognize a lot of these complexities and actively try to address those. And by doing those, that's what it means to situate power, because you recognize that. So for instance, I recognize the fact that this individual understands. It's a very simple thing, and I'm going to use an experience of mine. What does type 2 diabetes actually mean? You understand what it means to you, but actually a Southeast Asian woman who's not a fluent English speaker, maybe a second, third generation immigrant to this country, never went to uni here. What does type 2 diabetes mean to her? So again, I need to understand this. So how do I explain type 2 diabetes to her? So it could even be an individual who understands English, but they are not maybe medically, in terms of the medical lingo, they're not that conversant. What does type 2 diabetes mean to them? And how do I explain type 2 diabetes? But let's even complicate it a bit further. What does bipolar disorder mean to an individual in that circumstance? So again, this is the idea that when you're co-designing, if you haven't thought through how you're situating power with the individuals that you're going to be co-designing with, and by doing that, by actually giving them that agency to advocate on their own behalf, is one thing to understand, but it's another thing to understand and be able to advocate irrespective of your ethnicity, your education. If you haven't done that, then you're not truly co-designing. So to speak to your question, the long and short of it is, that we need to understand a lot of these complexities in the communities that we serve, and then actively endeavor to try that the individuals who are co-designing are reflective of the communities that we serve, and that we put in place approaches to ensure that a lot of those things, whether it's language, whether it's education, that rather than powerless, are actually barriers that we actively address so that they become powerful in that space. So whether it's by providing accurate translations for them, whether it's by providing accurate interpreters for them, etc. So that will be the way to do it. I agree. If I asked you again, Titi, you would say, well, it's going to be complicated, it's going to be expensive. But my question to you would be, is that a reason for us not to do it? So therein goes your answer. In terms of how we quality assure, I think it speaks to the first question and the response I've given, in that if you've truly situated power, then they will call you out. If you've truly translated and you've used you've used individuals who represent the community. If you think about the Bangladeshi community in Tower Hamlets, we have Bengali speakers, Sylheti speakers, etc. If you're co-designing and you're saying, okay, yeah, individuals in this room are representative of the Bangladeshi community, but you only have Bengali speakers in there. Well, you're not really, because you're excluding Sylheti speakers, right? So again, the idea is you need to have individuals who represent that community so that when you go on to translate, they can actually call you out and say, look, this translation is flawed. In the context of COVID and our response to COVID, we had a mirror image of what you have described, and we learned, we learned from that, in that, well, actually, sometimes when we are doing these translations, we get we subcontract it out, and then they make the translations. But actually, when they have done that, we haven't validated what has been done with a representative sample of the communities that we serve. So in the context of quality assurance, what we should do is to get a sample that represents that community to validate that indeed this translation is actually fit for purpose before it actually goes out into the community. So I hope that speaks to your questions, Titi.
Yes, I mean, absolutely. So I was just thinking, like, I know that all of these things need to go into, what we're doing, and it's certainly something that people know. Well, I'm just thinking that maybe as part of the toolkit, is there like sort of like a checklist in addition to what you currently have that just brings it back to people's minds again, to say, you need to check that you've done this quality assurance, you need to check that all the people you've spoken to are truly representative, you need to check that, just those kind of things that just sort of reminds people, so that when people are doing co-designing, we don't keep doing it in the conventional sense and like tokenistic kind of way.
Yeah, so what we've done with the toolkit is, if you reflect back on what is in the toolkit, there is actually a section there for comments. And what we've done is, and I think this was not in the toolkit before, it was one of our residents that actually said, you need to have this in there. And subsequently, we shared with the others and we're like, yeah, absolutely. And that's because they kind of mentioned the fact that there's this idea of this, that subconsciously as professionals, you kind of do things because you're used to, it's a norm, but actually we don't take that step back to sometimes reflect on the decision pathway. How did we come to that decision? So if say for instance, it says, have you translated, because translations is in there, and you say, yes, you've translated, and it tells there's like, what have you done for translation? Now, if you write in there, or I spoke to a Bengali staff on my team to validate this translation. Once you put that on paper, I'm pretty sure once you look at it a second time, you cannot tell yourself, well, I don't think this is rigorous enough. So what we've done actually is unwittingly ensure that by evidencing our decision pathways, we subconsciously reflect on whether it is good practice in the context of what we actually have done in being culturally appropriate. So that's the way the toolkit addresses that.
Thank you. Thank you very much. Super. Yeah, that's it for me.
Great. Thank you so much. I'm really glad that there's been some interesting points made, and it's clear that it's something that people are already considering in what they're doing. Cyril, did you have some specific points that you wanted to go back to?
I do. So
Okay.
I just wanted to share, open up to the group. I wondered if you have, I know that Kat has spoken to some thoughts as to, how she thinks the toolkit could support an area of practice of hers, but I just wondered if there were individuals in the room who had to have some ideas, some thoughts as to how you envisage that this toolkit can support you in your own various areas of practice. Or let me flip that. How can I support you to embed this toolkit in your areas of practice? What would you require of me towards ensuring that we kind of embed this and use this to underpin some of the interventions that you deliver?
Go ahead, Julie.
Hi, good morning. This is Salma from SheWise. I missed the beginning of your presentation, and I'm actually literally fascinated to hear what you, so far what I've understood of what you're doing. We are a small charity based in Hounslow, and Hounslow is predominantly over 50% ethnic minority, and we're doing a cancer research project with NHS, and also another one with mental health. Now, what I've understood from the toolkit, I think it would be really great for us at least for me to get in touch with you and to really understand this in much more greater details, because some of the points that's been touched upon is the translation element of it, because what it is that there's several aspects to translating material, and a lot of the time what we've noticed is the fact that the language is extremely hard, and it's not for a normal, standard layman's language, because nowadays what it is that we're actually ourselves generally I'm from Pakistan, but a lot of us are actually moving away from a standard language that we speak, and a lot of the hard books, the words that we've noticed on the flyers and NHS material is actually very hardcore. So there are several aspects to translation, and so therefore it'd be great to actually look at the toolkit in more detail from our perspective, and to see how we can really utilize this opportunity to translate in the correct language, and of course focusing on the community. For us, it's like there's a great difference between English as a second language and not being able to speak English at all. So therefore, you've got to keep that into perspective as well. So there's several elements to this, but like I said, I'm extremely the fact that I missed the early part of your presentation. So I would really love to have an opportunity to have this discussion with you in much more detail, to really give you in depth of the work that we're doing, if that's possible, please.
Absolutely, it is possible. I will be in your email, Salma. I will be sending you an email to catch up.
Thank you so much. That's excellent. Thank you.
Thank you. And go ahead, Julie.
I was just going to ask, I think it's from my perspective, thinking about this with my officers, is the support to be able to pass what you've now shared down in practical terms for them to be able to use on a day-to-day basis, because I suppose that's what I'm still struggling with now, how to take that toolkit and practically embed it into the service when we are having those conversations or we are communicating, well, the officers are on a day-to-day with our residents. I suppose that's where I'm like trying to find the joint, and trying to find in terms of giving them the power to be able to do that, and then reinforcing it and then coming back to it, so it's not just given and then it sort of starts for a while and then it drops off and we just go back to the way things were before.
That's a difficult one, but I think the best way to start will be to start small, in that, sharing the toolkit with them, exploring some of those issues, but more importantly, focusing on the fact that our decision pathways sometimes is this idea of unconscious bias. Sometimes you actually don't even know. You don't know that your education is actually a barrier. You actually don't know. You don't know that your position, in the council is actually a barrier. You actually don't know. And I think in the first instance is sharing with them to kind of reflect on what they do as a matter of course. What is it that you do every day? And how are some of these things evidencing what we do? So, for instance, what kind of languaging do you use? Is this perpetuating stigma? Is this perpetuating inequality? Have you reflected on that? So those will be the small steps. In terms of an intermediate step that you can do, and it brings me to my next point, it would be I'm intending to support colleagues in trying to adopt like a case study approach to the use of these toolkits. So for instance, it could be that you have a particular intervention or a particular message that you're intending to land in the next 2 months, in the next 3 months, in the next 4 months. So what we could do is we could work together in using the toolkit to underpin the design and delivery of that message. Once that is done, then I will generate a case study of how we used it to underpin that. So this will be a case study that says how we used trauma-informed approaches and cultural appropriate comms to underpin the delivery of a particular intervention. I'll just share what this case study would look like. So it will be 2 pages. The first paragraph will just be background context. Why did we do what we did? What was the issue that needed investigating or needed addressing? And what kind of evidence did we have? Anecdotal evidence, data, etc. The next will be what we did. How did we actually use the toolkit? Did we co-design? Did we try? What did we actually do? So that will be the next part, and that's the first page done. The second page will be impact. So once we have designed the intervention and delivered it, I will then come back to the individuals that the colleagues in the team. I have conversations with them. How did you find using the toolkit? What worked well? What did not work well? And how do we improve? I will go to the individuals who received the message, have a couple of interviews with them or conversations with them. I should adhere to what I preach. I would have some conversations with them, and the conversations would be, did you find the message you received culturally appropriate? If yes, why? If no, why? It's as simple as that. No complicated conversation at all. Very, very simple conversation. But what that will do would be it gives me evidence of impact. And then that will be the second page of the case study. And together, so this would not be a case study that I generate myself. It would be say I was working with the case study with yourself, then you would be first author on that case study. I'll just be supporting you. So I'll be writing it up. But of course, everything I write, you would have to validate, you have to check that it is an accurate representation of what was done. The only bit which will not entail you doing would be the analysis of what I was told. But once the case study is ready, you would have sight of it. You would first of all sign it off before it is then shared. So that case study can then be shared with other colleagues in your team, and you can then encourage them to do more of the same. They don't have to write a case study, but they can then use the toolkit to underpin messages, interventions that they intend to deliver moving forward. So that's the general idea. But for all the partners in the room, that's currently what I'm doing now. So if you have any intervention, if you have any message, then please feel free to reach out to me and I can work with you in using the toolkit to underpin what you're doing and then generate that case study, which is then evidence of how we have been trauma-informed, culturally appropriate in delivering that intervention as well.
I think,
Right,
thanks.
thank you.
Yeah, I guess just to wrap it up, I suppose reflecting what Cyril said, it's really important to kind of, I guess, like acknowledge the small steps forward that you do make, because then people do feel a bit encouraged that they're heading in the right direction if that's what's happening. And then you can kind of build off of what you're doing. So not necessarily putting so much pressure on officers to do everything from the jump, but more so like small steps and seeing how that actually helps, and then you can add new bits to it. Unless there are any final comments or questions for Cyril. Cyril, was there any kind of final parting words? I suppose that was a call to action around, should I share your contact details when I send out the final slides? And okay, great. Thank you so much, Cyril, for your presentation and for everyone in the room for contributing. We can draw the session to a close, and I'll be sending out the recording slides and Cyril's email if you want to get in touch with him.
Thanks,
Amazing.
everyone.
Thanks, everyone. Thanks for joining so early this morning. Have a good day.
Thank you.
Take care.